So if you're really good musculoskeletal providers, I don't care who you are, if you're a chiropractor, PT, massage therapist, you're not diagnosing, but if they're trying to fix pain, they should know what they're dealing with. They need to know what tissue has what problem. If somebody has a really bad sciatic nerve problem and they're just going to massage on the butt cheeks because that's what they do, that's not really serving people. Or if I'm a chiropractor, I'm going to adjust their bones and their joints and they have some disc problem or some other nerve entrapment problem, and then they F up their neck, that's not really serving people. So we, as Adhesion Release Methods providers, need to do better.
Remember when Larry came in and he had this left whole thoracic symptom and rotating to the left and then rotating to the right. He had both sides, the whole thing, and then plus a low back symptom. And my question was just, how do you know what to start, or where to go, or like, all right, you see all this information, there's a lot of things you're looking at, where do I focus? You went to thoracic rotation.
Yes. The step 1 of Adhesion Release Methods with that history sheet, where you take the 7 first order data points. So it's age, sex, LQI, location, quality, intensity, provocative, and palliative. We do that at the console before we do the exam. But that process is basically occurring in my head every time they have a symptom, because that's how you figure out what tissue has a problem or a pathology that needs to be fixed. So he had bilateral thoracic symptoms in his whole low back. So first, just with that location, what's going to cause that type of symptom? What tissue is going to cause that type of symptom?
I think the erectors, because that's the whole thing.
One area of adhesion is not going to cause a gigantic area of problem.
Joint.
Yes. But so that's one of the first principles that maybe you weren't appreciating yet, is that, you just because muscle exists somewhere doesn't mean that adhesion is the problem if they're pointing that spot. What tissue can cause this gigantic area? And it's likely a disc problem. Usually it could be the facet joint, or it could be a hip joint problem shooting to the entire thigh or leg. But that's part 1, and that's where my head goes. So if I'm thinking that it's a disc based on that location, then I need to know what the other quality, intensity, provocative, and palliatives are to figure stuff out. So then we start doing, I think you asked me what test to do. So it's thoracic, I want to know what thoracic flexion, rotation is like. And then I want to know the hip extension, kneeling hip extension, see what the belly stuff is like. And then that'll get, if a range of motion is really restricted, that's going to tell me where to go. Or if something's very provocative and it tells me what symptoms, very pissed off, it's going to tell me where to go and look. So if all of those tests are really good except thoracic rotation to the left, then when he rotates to the left, instead of feeling this gigantic area, he feels a smaller spot on the left side, then I'm going to look for rotatories multifidus on the left side. So all that symptom information and data, and then the provocative movements, the palliative movements, and then palpating and feeling, and I'm going to try to find that one worst area of adhesion. So if I do 1 or 2 passes, I can be done with that.
Right. And tissues is not just muscle. That refers to like ligaments, tendons, joints. When I think of tissue, I think of muscle. That's where my mind goes.
No, false. A group of cells is a tissue. Your hair is tissue, I believe. Your skin is a tissue. The parts of your eyeball, the white part of your eyeballs is all tissue. So a bunch of cells of muscles, a bunch of cells of ligaments, a bunch of cells of tendon. These are all tissues. So muscles, ligaments, tendons, nerves, organs, bone, these are tissues. So if you know those are your tissues, we all have that. Fascia, we all have fascial tissue. Pathology is a problem. So what tissue is having what problem? And that's your diagnosis or your hypothesis for what your diagnosis is. And so if you're really good musculoskeletal providers, I don't care who you are, if you're a chiropractor, PT, massage therapist, you're not diagnosing, but if they're trying to fix pain, they should know what they're dealing with. They need to know what tissue has what problem. Because if somebody has a really bad sciatic nerve problem and they're just going to massage on the butt cheeks, because that's what they do, that's not really serving people. Or if I'm a chiropractor, I'm gonna adjust their bones and their joints, and they have some disc problem or some other nerve entrapment problem, and then they F up their neck. That's not really serving people.
Right.
So we, as adhesion release methods providers, need to do better, and that just means getting really good at that iterative step one process of what are the first order data points for their symptoms, and then go from there.
I definitely feel like I have not been appreciating the signs of a disc, or like the bigger the area, I think of like the bigger the muscle versus one thing is causing that.
Say that again?
Like when I see symptoms of like a bigger area, you would think disc or joint. I haven't been thinking like that, so now it's a good key or something to put in my brain, like, oh, it could be something referring, it could be a scleroderma, it could be...
Sure. Well, in about 6 weeks, you're going to start treating patients. So you're going to go through this process, and you're going to have a guess, and then you're going to treat them once, and maybe you're going to treat them 2 times, maybe you'll treat them 3 times, or day 4, day 5 comes in, and maybe they're going to come in and be like, Kasey's the same. Kasey's the same. It's the same. And then maybe they either self-discharge from your care and they stop coming in, or maybe they tell you, like, I want to stop coming in. And then we will probably talk way sooner than that. But let's assume we didn't talk and I wasn't there.
Right.
You would probably, or hopefully, go back to the drawing board and say, did I miss this diagnosis? You'll rework your diagnosis or figure out what you missed, what principle you weren't paying attention to, rework it so that it makes sense to you now, and then your treatment will be different. And then hopefully when they come back in, they'll be 15-20% better. So that's why it's called practice. It's you're learning, your practice is your skill set that you're trying to master.
Thank you.
You're welcome.